Good afternoon. My name is Lori Tischler. I am a longtime faculty member at the Brigham in the Department of General Internal Medicine, and I spend my days now working at Commonwealth Care Alliance, which is an organization that provides care for 40,000 people in Massachusetts who have dual eligibility for Medicare and Medicaid. Our goal is to go through some internal medicine questions today. The questions that I chose are things that you might encounter in daily practice, but that you might not encounter in other sections of this course. So we'll talk about all of those things, and I'm putting it together as if you're having a morning in clinic. So let me just start by saying that I have nothing to declare and no conflicts of interest. And the custom sign seemed a whole lot funnier last year when we were all allowed to travel. For case one, I'd like to talk about screening for breast cancer and women who are at high risk to have the BRCA gene. So, case one. A healthy 38-year-old woman presents to your office for an annual physical. Her 46-year-old sister was recently diagnosed with breast cancer, and she's wondering if she should have an MRI. Her past medical history includes a benign breast biopsy when she was 28, 2 normal pregnancies at ages 32 and 34. She had menarche at age 11, and she has currently regular periods. Her only medication is an intrauterine device. Her family history is notable for the sister that we already talked about, her mother, who had postmenopausal breast cancer at the age of 65, and a maternal aunt with ovarian cancer. There's coronary disease on the paternal side and thyroid disease in a third sibling. Her social history is notable for being married with 2 children. She works as a teacher. She's active in her synagogue. She doesn't drink or smoke or use any street drugs, and she's not been a victim of domestic violence. Her physical exam is completely normal. So, first question here is, what is her lifetime risk of breast cancer? And some of you may have guessed correctly, and others of you may be surprised that it is as high as 35%. So let's talk about that. You can actually you can go to www.cancer.gov, BC Risk Tool, and you can answer the following questions for a patient. And I gave you all of the answers to the questions in the case history. Race and ethnicity, whether or not they've had a prior history of breast cancer, how old they are now, their age at menarche, how old were they when they had their first live birth, how many first-degree relatives had cancer, and whether or not they've had any biopsies, and whether any of those biopsies showed atypical hyperplasia. So this is called the Gale model. It's important to remember that the Gale model was introduced as a research tool for populations. So it doesn't tell us, it tells us that a population of women who met these criteria, right, all of these criteria here that I'm circling with the cursor, would have a 35% lifetime risk. It doesn't tell us specifically what this woman's lifetime risk is. And that's hard, I think, for both patients and doctors to understand. But it does give us a ballpark for saying she's very high risk and we might want to act accordingly. So this is, as I just said, the caveats are this underestimates the risk for people who are gene positive. So if our patient is actually carrying BRCA1 or 2, her risk is actually higher than 35%. And the Gale model does not factor in other risks for breast cancer, including breast density, which we'll talk about a little later, and a history of chest wall irradiation, as somebody might have gotten during treatment for Hodgkin's disease, particularly during breast development. That being said, I'm going to ask you now, what's the recommended screening for our patient who has a high risk for breast cancer and a risk in her lifetime of 35%? The current recommendation for our patients is getting an MRI and a mammogram each year. Now, people could get the MRI and the mammogram at the same time, but for reasons to me that seem like common sense, it's reasonable, for example, if we were going to screen a woman with a mammogram in July, to have the MRI 6 months later in January. Um, and the recommendation, right, the key points to this recommendation is that anyone with a lifetime risk of breast cancer who of 20% or more should have both the mammogram and the MRI. In our patient, I would consider referring her for genetic counseling for people at high risk. It really depends on your practice and your access to resources. But where I practice in a big city with a lot of resources and we have high risk breast cancer clinics, I think it's very important for women to understand what it means before we test them. For women, men, anyone, what does it mean before we test somebody for BRCA1 and 2? What would the risk be of the testing? What are the benefits? What would she choose? Um, what would she choose? And so for those reasons, I would actually consider referring this person for genetic counseling. And the reason that I threw in that piece of her being active in her synagogue was to suggest in your clinical mind that she may be an Ashkenazi Jew and therefore have a higher risk for BRCA1 or 2. Also, more than possible that the sister who had breast cancer at a relatively young age might have been tested. And that's something worth finding out for your patient as well. Of note, the current US Preventive Services Task Force recommendations would not apply to our patient because of her particularly high risk. What I ask everybody to do each year as I update this talk, I look to see if finally recommendations have come out around breast density and new risk calculators. Um, we don't have we don't know the answer to that yet, but those are the things that keep your eyes out for new data and the new developments in this space. All right, your patient's pretty happy. She's going to get her Q6-month MRI and mammogram. She's going to think about whether or not she wants to consider BRCA testing or at least seeing a genetic counselor to consider whether testing is a good idea. And then she stops to say, well, look, my mother-in-law is 86. She has progressive dementia and Parkinson's disease, and she's kind of wondering if her mother-in-law still should have mammograms. The mother-in-law's mobility and comprehension are severely limited, and she's been living in a skilled nursing facility. So what do you do? Screen the mother-in-law? Okay. If it's me, obviously it's going to be up to the family, up to her mother-in-law, to the extent that she can participate in the decision. But I would really suggest that for this woman with multiple comorbidities and advanced age, that this is probably not necessary. So this brings us to the question of when do we stop screening? Well, there's no good evidence for screening after the age of 74. So the real questions we need to ask our women patients over the age of 74 is, what is their overall health status? Are they incredibly healthy and running in the under 80 division of the marathon? If so, then, if so, and it's that woman's preference, you might in fact want to offer her a mammogram. If you think she's going to live more than 5 to 10 years, you might want to offer her a mammogram. And then importantly, how would she, or in this case, her healthcare proxies, act if she were in fact diagnosed with breast cancer? And this is really a very individual decision. What I've seen in my practice, I have women where I personally would make the decision for them that it's reasonable for them to continue getting mammograms, and they tell me no, that they have no interest in doing that. So it really is, it's a quick conversation. It's something that many of your patients will have already thought about, and that you should think about as well in terms of the advice that you're going to provide for a patient. It is, I think, something that I've realized as I go on in my career, that our patients not only are looking to us for what the data is, but for how to interpret that data in their particular setting. Okay. For cases 2 and 3, we're going to talk about red eyes because this is your primary care practice and things change every minute. So, 50-year-old man comes in with a huge red area in his eye. He's in good health and he recently carried many boxes to his attic. He has no pain in his eye. His vision is 20/20 with your little Snell card, and he's worried that this occurred because he missed his antihypertensive meds over the last few days when he's been working so hard on his house. This is what he looks like. Okay. So what's your diagnosis? All right, this is a subconjunctival hemorrhage, and I'm going to go back now to the picture and just point out a few things. This is scary looking. It's scary for patients. It terrifies new residents. It is not dangerous. But one thing that makes me not worried about this patient is what you're seeing here with the cursor, this white area around the iris, which is called limbic sparing. That is extremely reassuring that this is a subconjunctival hemorrhage. And if your group is anything like groups in other years, you probably all knew this. And just going back, it is not dangerous. It will resolve on its own, and it's just essentially a burst blood vessel. It's possible that carrying the boxes to the attic increased his valsalving and intracranial pressure so that it might have caused that blood vessel to rupture. Patients are always very worried that it's a sign of hypertensive urgency and emergency, and it is not. Okay. In this case, so you took care of that person, they left, they were incredibly reassured, and then a 50-year-old woman with rheumatoid arthritis comes in to see you. Her disease has been very active lately. She's feeling lousy, and since yesterday, she's had photophobia, and both eyes are painful and red. Okay, this is what she looks like on exam. She's clearly in pain, and if you press gently on her eye, it hurts her a lot. She's asking you to turn down the lights in the exam room because the light is bothering her. She has photophobia. By some miracle, you were actually able to get a SED rate before seeing her, and it was 100. And phenylephrine drops in your little eye kit that you just drop into her eyes don't clear it at all. So what has she got? Okay, she has scleritis. And if, again, if you're like your peers in other years, you were probably split between scleritis, acute angle closure glaucoma, and episcleritis. Rheumatoid eye is not a real disease. The things to know, because episcleritis is not serious at all, but scleritis is an ophthalmologic emergency. So the difference between them is episcleritis may be local or diffuse, will resolve without treatment, does not affect vision, and those phenylephrine drops will lead to transient resolution. And the reason that they'll lead to transient resolution is that by vasoconstricting the episclera, the sclera is normal underneath and the eye will look normal. Scleritis, on the other hand, is an ophthalmologic emergency. It's a striking, highly symptomatic course. And again, this woman, she doesn't feel well. She has systemic symptoms. It's painful. I think many of you, if not all of you, probably know if you have pain in the eye, like true kind of boring pain in the eye, or loss of vision, these are things that are ophthalmologic emergencies. These are things that you want to get somebody into an ophthalmologist today, yesterday maybe. It's painful. People have photophobia. This is vision threatening, and people are going to need ophthalmologic and systemic treatment urgently. So if you're practicing somewhere where you have access to an urgent visit with an ophthalmologist, that's the way to go. If not, you're going to want to get on the phone with one and figure out what the right things are to do while a patient is waiting or traveling to see an ophthalmologist. And certainly if you're quarantined, again, this is something that you could potentially diagnose in a virtual visit, but you want to make sure that you're also treating it very quickly. So we would generally treat this with systemic steroids. So again, if for some reason you were in a place where you had no access to ophthalmology, you would probably want to start somebody on steroids and then also get a hold of an ophthalmologist. All right, so you have taken care of the ophthalmologic portion of your day, and you see one of your favorite patients. She's a 92-year-old community dwelling elderly woman brought in by her 73-year-old daughter because she fell again. Sounds familiar probably for many of you who are either doing geriatrics or primary care. You quickly ascertain that she is not injured. She's only got wounded pride and a sore bottom, but you review her history. The fall occurred at home when she got up from a chair and headed to the bathroom. She lives alone. She doesn't drive. She has a walker, but she ignores it. And she takes multiple medications, including atenolol, hydrochlorothiazide, lisinopril, insulin, and metformin. At night, she takes amitriptyline for her diabetic neuropathy. She also drinks alcohol, though she's never admitted this to you, and you've learned this from her daughter. And this is a disguised case, but in the case that I had, that was fairly similar. The daughter took me aside, and remember, meets the definition of elderly as well, and said, "You have to know that mommy drinks." Okay. You have a limited physical exam. Maybe you're doing a virtual visit. What of these tests are going to be the most helpful for you? Okay, and I'm guessing that most of you will have picked a functional exam. It's not to say that any of the other exams wouldn't be helpful to you, but the functional exam will give you more predictive information. So there's a test, which you may have heard of, called the Get Up and Go test. And basically what you're going to do is you're going to record the time that it takes a patient at risk to get up from a chair, walk 10 feet, and return to the chair. In the practice that I practiced in for many years, we actually roomed our own patients. So when I got a patient from the waiting room and brought them into my exam room, we had our get up and go test, and you could tell a lot of things very quickly. If it takes more than 30 seconds to walk 10 feet, they have impaired mobility and are at a much higher risk for a fall. So we do the up and go test, and she scores 31 seconds, a marker of impaired mobility. So we send the visiting nurses to her house to do a home safety assessment, stress the importance of using her walker at all times. We stop the Elavil and try something else for her neuropathy because I was worried that she would have orthostatic hypotension. And we address the alcohol again as well. What's the likelihood of recurrent falls? So of the 1 in 3 elderly people who fall every year, what percentage of them have multiple falls? Half of them, okay? This is falling in the elderly is not something that happens to any specific demographic. In some ways, it's like domestic violence. It transcends socioeconomic class, it transcends race, it transcends where people live. Older people are often at risk of falling. Um, We had at one point in our family, we had 6 elders that we were taking care of, and 5 of them fell in a year. Um, One had dementia, and the other 5 were extremely functional, but they were still at high risk for falls. So this is Alice B. Davis, who played Alice on the Brady Bunch. And since we've all been living the Brady Bunch on Zoom, she seemed a good person to include. Um, I'm sorry, it wasn't Alice B. Davis, it's Ann B. Davis. And she fell in her bathtub and sustained a subdural hematoma. She was 88 years old and she died. This is Kurt Vonnegut, who died from a traumatic brain injury after a fall at his Manhattan home, age 85. Fun fact is that this photograph was taken by his wife, photographer Jill Kremnitz. So this is just to remind you, anybody can fall. People with lots of resources can fall. People with no resources can fall. And there are ways to prevent falling. So falls in the elderly are responsible for 70% of accidental deaths in people who are 75 or over. As I said, it increases with age and transcends ethnic and socioeconomic groups. It is a cause of significant morbidity, including decline of functional status and risk for hospitalization. I think we all worry about hip fracture because it's such a morbid event for patients, but it occurs in 1 to 2% of falls, but serious injuries occur in 5 to 15% of falls, and really can make the difference in somebody having an a period of time as an older person where they're able to live safely at home, um, and it can change that. So these are the things that we can really help our seniors with. And if we talk to most seniors, they're very afraid of falling. Some not afraid enough to use their walkers, but they are afraid. So there are sort of intrinsic and extrinsic risk factors for falling. Intrinsic, muscle weakness, gait and balance dysfunction, visual or cognitive impairment, orthostatic hypotension. Meds are probably both intrinsic and extrinsic as I look at this. But there are other things, poor lighting, clutter, environmental obstacles, bad shoes. These are all things that are extrinsic. And we can work on all of them. I mean, all 10 of these bullet points are things that we can make a difference in keeping people safe. And let's talk about the fact that I had a 92-year-old patient who drinks. So lifetime alcohol abuse in a study in the emergency room was 24%, 14% of whom had had problem drinking in the last year. Elderly patients who present with GI complaints had a much higher risk of alcohol issues, 22%, than those who fell down. And we, as a group of physicians, are lousy at determining alcohol abuse in the elderly. Only 21% of the cases of current abuse were detected by patients. So, encouraging all of us to really think about substance use, substance abuse, and addiction in our elderly patients. As well as mental illness and persistent mental illness. It may be quieter than it looks in patients who are younger than 65, but it's there and we can really make a difference and help people. All right. Cases 6 and 7 are workplace related medicine. And this is something that I think many of us who practice primary care do a good amount of and don't always feel comfortable doing. So JM fell in her work at a local discount store about 7 or 8 weeks ago. She has been complaining of pain in her lower back ever since then. Treatment with nonsteroidals and muscle relaxants didn't really help. Her imaging was negative, and PT likewise did not make a difference at all. Her symptoms are out of proportion to both what your assessment of her injury and to your exam. She seems much more uncomfortable, but when you do an exam, she is you're not finding much. And she says, I just don't think I can go back to work, she says tearfully. I'm not ready. So, what do you tell her now? And I'm just going to remind you gently that it's not what do you want to tell her, but what do you tell her? And what do you do? Okay. As much as some of you may have wanted to write A, the answers are B, C, and D, right? We're going to look to see if she's depressed. We're going to work with her company. She works in a discount store, a big box store, to come up with a transition back to work plan. And we're going to inquire about pending litigation. Okay? The vast majority of people who have a work-related injury get better and go back to work, just like the vast majority of people who have back pain get better. Um, Things that might keep a patient from getting better may include the way that they perceive pain, the way that they perceive their injury, whether or not they have depression, a pending lawsuit, or other evidence of secondary gain. And you don't mean this necessarily is malicious, right? Someone's secondary gain might be as simple as the kids are helping with the dishes. And they've not done that before, and it's really helpful. And if her back gets better, she's afraid they're going to stop. Okay. Factors at work may include the inability to provide transitional employment. The truth is, most companies of any size have some protocols for occupational health and will work and think with you about how to provide transitional employment. Our own factors as physicians include our discomfort with knowing when patients are stable to return to work and our desire to help people with a bad situation. I mean, sometimes people have really crummy work situations, and you just, as a clinician, want to be helpful. And while you might be being helpful in the short term, you may not be being helpful in the long term. And one of the important things to know is that if a worker has been out more than 6 months, only 1 in 2 of them, only half of them, will ever return to work after an injury. Okay, this is a different kind of case. It's a work case, a work-based exposure. So this is a patient who has lead exposure as in his work as an instructor in the police academy firing range. He comes in to follow up after a hospitalization for a left-sided facial droop and a right-sided hemiparesis. While you discuss his recovery from what is quite likely a stroke, his wife tells you she's pretty sure this isn't a stroke at all, but this is, or that even if it's a stroke, it's that lead poisoning caused his stroke. Okay? So what's the correct response here? Is she right or is she wrong? She's probably wrong. It is very uncommon for occupational exposures of any kind to cause focal neurologic problems such as strokes. People's symptoms from occupational exposures tend to be much broader and more systemic. So it's still worth noting, right, that when we think about the risks for cardiovascular disease and stroke at work, it's highest in people with service jobs and blue collar jobs, particularly in accommodation and food service. Um, as I'm reading all of this, I'm thinking a little bit ruefully that this has all been pre-COVID, but hopefully we'll get back there one day. Risks may include for people the stress of work, shift work, and exposures to secondhand smoke and other particulates. But going back to our patient, I would probably want to be following his lead level. There is another test that you can actually follow because he is exposed to lead on a regular basis. And the other test is called a free erythrocyte protoporphyrin level. And that is a measure of lead exposure over time, kind of similar, and it measures the way that the lead sticks to a red blood cell, and that is sort of similar to the way a hemoglobin A1C would work. So we would follow that patient. I have had people with lead exposure at their work, and they are, and we do follow either a lead level or a free erythrocyte protoporphyrin. Okay, many patients have gastric bypass surgery. And after gastric bypass surgery, a 45-year-old female patient presents to your clinic to establish care. She's new to you. And her past medical history is notable for diabetes, which she proudly tells you is in remission after gastric bypass surgery 5 years ago. She followed up with her surgeon for a year or two, but since then has not really been seen by a physician. She has, however, maintained her weight loss. She currently takes no medicines, no herbal supplements, and no vitamins. The remainder of her history and exam are unremarkable. So, what labs would you order? Remember, history and exam is fine. So, the answer here is C, that you want to check her A1C, right, to ensure that she remains in remission with her diabetes. B12 and vitamin D as fat-soluble vitamins, and a CBC because she's at risk of iron deficiency anemia. This patient, along with so many other people who've been very successful with gastric bypass, will often sort of drop taking their vitamins. And the reason that it's important that they take their vitamins is that gastric bypass does exactly that, right? It bypasses the small intestine, it bypasses some of the stomach, and they're going to have malabsorption. So they may really need to be on higher doses of these medicines for lifetime. So late complications of gastric bypass. The most common are anemia, as we just discussed, and vitamin B12 deficiency. Incisional hernia in about 10%, depression and emotional disturbance in 5 to 10%, very rarely, ulcers at the anastomosis site, also very rare electrolyte abnormalities, small bowel obstruction. Cholelithiasis is often a much earlier complication and not a late complication of gastric bypass. So we want to make sure that we're following this, asking patients these questions, making sure that not only are they maintaining their weight, but that they're getting adequate nutrition as well. Okay, case 9, unilateral hearing loss. Can you talk to my good ear? A 36-year-old man calls your office with a complaint that he woke up and he can't hear out of his left ear very well. He has no history of ear problems, no recent infections. He traveled recently on an airplane and wonders if it's because of the plane. And certainly he's socially distanced and wore his mask. Your astute triage nurse had him hum, and the humming didn't lateralize to one ear or the other. He has no vertigo, but he does have tinnitus and a little bit of pain in his ear. So what do you do now? Okay, you're going to worry. This person could hear perfectly fine yesterday, and today he can't hear out of one of his ears. And this is an emergency, or at least an urgency, whether you can see him yourself or refer him to ENT. Okay, this is called sudden sensory neural hearing loss. It's rapid hearing loss that's usually noted over a 12-hour period or when the patient wakes up in the morning, most commonly just because they notice a change in their hearing after being asleep. It is usually, but not always, unilateral. And more than 90% of patients have some tinnitus with it. Often people also have a sense of discomfort in the ear or a sense of ear fullness. The etiologies for sudden sensory neural hearing loss are myriad, but most commonly autoimmune, microvascular, or a viral cochleitis. Depending on the series, the risk of an acoustic neuroma, a retrocochlear tumor, ranges from 3 to 30%. It is recommended to get an MRI to evaluate the retrocochlear space when someone has sudden sensory neural hearing loss. Treatment, Again, no clear agreement on best protocols, but most ENTs will treat with high dose glucocorticoids of 60 to 80 milligrams a day for 10 days. Some studies suggest that people will heal or get their hearing back faster with a steroid treatment. For people who fail oral steroids or who can't take them, there's limited data about using intratympanitic steroid injections. And a small subset of patients may improve with antivirals. The prognosis is generally good. The prognosis is better if there is high frequency hearing loss or low frequency hearing loss, but not hearing loss across the board. And the frequency and the prognosis is better for younger patients. May take up to 4 months to resume hearing, which may never be complete. And finally, in people who experience hearing loss with vertigo, the prognosis may be worse because it may be a sign of a different disease, like Meniere's disease, for example. And I think this is our final case, transgender medicine. We have a new patient coming to see you. She's a trans woman, meaning that she was assigned male at birth, but has chosen to live as a woman since her young adulthood. She's been taking estrogen and testosterone blockers since her late teens, and now she's 50. She has not undergone gender affirmation surgery. So, what cancer screening is most appropriate for this 53-year-old woman? Okay. A breast exam and a mammogram, as well as colon cancer screening. Why? It's really as simple as this. While you're going to screen the organs that are there, right? She does not need a PSA because since she's taking, well, she might not need a PSA anyway. But if you were inclined to get one, she does have a prostate. But given the estrogen exposure, it's probably extremely non-active, but she does have breasts, so she needs a mammogram, and she does have a colon, so she's going to need that. She doesn't need a pap smear because she doesn't have a cervix. So the key thing with people who are transgender is to screen what's there. I've never seen a transgender patient, you think to yourself. This is probably not true. A phone survey in Massachusetts found a self-reported prevalence of 0.5%. Okay, the key thing is be empathetic, non-judgmental. Don't assume that you know someone's sexuality based on their gender, right? There are trans women who are straight, there are trans women who are gay. You want to provide sensitive care and honor the patient's gender identity by using the pronouns that they choose to use for themselves. And the bottom line, again, is you're going to provide care for the anatomy that is present. You don't need to assume that your patient who is transgender is depressed, but you should be aware that depression, anxiety, and substance abuse, as well as trauma, are more common in the transgender population. So there are no clear recommendations here, but you should know that half of people in some studies meet criteria for depression. Especially transgender youth may be at higher risk for suicide. 16%, about 1 in 6, which is about the same as in the general population, are at risk or have a history of substance use disorder. There's some great resources for transgender care, which I've shared with you here, if it's something that you're not familiar with and feel like you want to learn more about. And I wish you all extremely good luck on the boards, and I still have nothing to declare and no conflicts of interest. Thank you very much.